Thank you for joining me today. This is the second part of a psychiatric disorders. We went to go over the part 1, and we want to continue more psychiatric disorders. We want to go over the symptoms. We want to go over the causes, mechanism. We want to go over the clinical presentation of a psychiatric disorders, how to diagnose the psychiatric disorders, differential diagnosis, treatment selection, and clinical follow-up or next clinical steps to choose. So we want to talk about OCD disorders, obsessive compulsive disorder and related disorders. What causes the OCDs? OCDs is a primary associated with dysfunctional in the cortico-striatal cortical circuits, serotonergic modulation of obsessive thought inhibitor, overactivation of error detection systems in the anterior cingulate cortex. This results in persistent impulsive thoughts, inability to execute treat signals. What are the symptoms of OCDs? Symptoms of OCDs include impulsive, repetitive behavior, unwanted thoughts, images, urgency that are experienced as distress or ego-dystonia. So patient is, if they have an impulsive, they are going through impulsive, repetitive behavior. They are having unwanted thoughts that's coming to them. They are going to see images or urgency that are expressed as a distressing or ego-dystonia. If they are having a compulsion, because OCDs is a obsession and compulsion together. If they have a compulsion, they are having a repetitive behavior or mental acts performing to reduce this anxiety and prevent the fear outcome. Insight is often perceived but can be vary from a good to absent. Can be vary from good to absent. Symptoms are sometimes consumed significantly impair function. So the symptoms are time consuming and they impair the daily tasks and daily functions. Differential diagnosis and diagnosis reasoning. So the diagnosis requires presence of a obsession and impulsive or both. Recognition that the behavior are driven by the anxiety reduction or harm prevention. They are anxious, they want to reduce the anxiety, they want to prevent the harm. Some of them, they are scared of infection, so they are washing hands. That's a typical of OCDs. This behavior is significantly time consuming and impairs the function. Differentiation from a psychiatric delusion, with which are the ego-dystonic or fixed. Differential diagnoses include psychiatric disorder with delusions versus OCD inside of ego-dystonic nature are key differentiation. So if they are psychiatric disorder with delusion, are they having we want to differentiate if they are having a psychiatric disorder with delusion or if they are OCD disorder, or if they are having an OCD disorder. And the key differentiation is they are having an insight and ego-dystonic nature, because they are not detached from the reality. People who are having a delusion, they are detached from reality, but OCDs, they are not detached from reality. We want to also differentiate between general anxiety disorder versus OCD. Worsening is the less ritual and more diffused. OCD worries is less ritual and more diffused. That's the difference between general anxiety disorder and OCDs. We want to also differentiate autism spectrum repetitive behavior with compulsion. Autism behavior are typically ego-syntonic, brushable, or self-suitable rather than anxiety-driven. So autism behavior is self-soothing, not anxiety, but obsession, they want to calm their anxiety. Tic disorder versus compulsion. Tic are more motor-based, not driven by impulsive. So that's how that's how we can differentiate tic disorder versus compulsion disorder. Tic are more motor-based, not driven by impulsive cognition. So the first line treatment is a psychotherapy, exposure, and response prevention therapy. OCD first line of therapy is psychotherapy, exposure, and responsive prevention therapy. First line pharmacotherapy is SSRIs at the higher than depression doses. So they will be having a high dose of, we will prescribe high dose of selective serotonin reuptake inhibitor. We want to also, they can have clonidipramine, may be used in the treatment of resist cases, treatment resistant cases. So if the treatment is not working or they are resistant to the treatment, we want to prescribe clonidipramine. It is TCA antipsychotic TCA medication. We want to also have strategy that include a typical antipsychotic, such as we want to add on that a antipsychotic medication such as Risperdal if they are resist to the treatment. Next, we want to assess the degree of a functional impairment and time burden of the compulsion. We want to initiate exposure and respond prevention therapy earlier. We want to escalate to higher dose of SSRIs if the partial dose is not working. We want to consider adding other medication only after a adequate trial, after we try the SSRIs and the therapy. We want to add another one only if the treatment that we try is not working. PTSD disorders and trauma-related disorders. PTSD disorder is associated with hyperactivation of amygdala fear center, impair prefrontal cortex, inhibition of a fear response, hippocampus dysfunction affecting a contextual memory process, dysfunctional hypopituitary excess stress response. So PTSD is associated with these causes. The causes could be hypoactivation of the amygdala fear center, impaired media prefrontal cortex, inhibitor of the fear response, hippocampal dysfunctional affecting the cortical memory process, dysfunctional hypothalamus pituitary excess stress response. Those are the causes. And the symptoms that present when they have any PTSD include intrusive symptoms like flashbacks, nightmares, distressing memories, avoidance of a trauma-related stimuli, negative alternation in a cognition or mood, like the guilty, detachment, persistent in negative belief, hyperarousal, like a hypervigilant, exaggerate, visceral respond, sleep disturbance. Those are the symptoms of PTSD. Diagnostic reasoning, we want to rule out, and that is required. Diagnostic requirements include exposure to actual or threatened death, serious injury, or sexual violence. It's required that they been exposed to the actual threatened to death, serious injury, or sexual violence. Symptoms lasting more than 1 month. Clinically significant distress or impairment. So to be diagnosed with PTSD, they should be exposed to actual or threatened to death or serious injury or sexual violence. They should be exposed. Not should be. It's required that they have a history of these things. They are having symptoms that last more than 1 month. They are having a significant distress or impairment. They are having, we want to also exclude this symptoms is not caused by substance induced or medical causes. Sometimes substance can cause stress disturbances, symptoms similar to PTSD or medical cause. So we want to rule those one out before we diagnose them with PTSD. Diagnostic differentiation include acute stress disorder versus PTSD. Is this acute stress disorder or is this a PTSD? Duration less than or greater than 1 month. That's how we can differentiate these two diagnoses. We want to differentiate between major depression disorder versus PTSD, and the difference is presence of a trauma-related experience symptoms. The difference between major depressive disorder versus PTSD disorder is that the person have experience with trauma that related, and they are having a re-experience the symptoms. They are having a flashback for that trauma. They are seeing that trauma now. General anxiety disorder. We want to differentiate between general anxiety disorder versus PTSD, and then how we can differentiate is the worry is more. Worry is not from trauma specific. general anxiety disorder, their worries is not from trauma. But PTSD, their worries is from history of trauma that they had. Personal, we want to also differentiate between borderline personality disorder versus PTSD disorder. Both diagnoses may include affect instability, but trauma re-experience is a key in a PTSD. Borderline personality disorder, they may not have a history of trauma, but PTSD, they have a history of trauma and they are re-experiencing that trauma now. That is why they are having these symptoms. They are seeing visuals or nightmares from the trauma. Treatment for PTSD include trauma reinforced cognitive behavior is the first line of psychotherapy. Eye movement desensitization and reprocessing therapy as a evidence-based alternative. Also, SSRIs such as Zoloft or paroxetine is the first line of pharmacotherapy. Paroxetine may be used for trauma nightmares in some patients. Next, we want to assess the safety. Risk safety include SI, substance usage. We want to initiate trauma, focus psychotherapy as a primary treatment, treat the comorbidity, depression, or anxiety with SSRIs, avoid benzodiazepine as a long therapy due to a dependency risk and limit efficiency. So we want to assess the safety risk. We want to initiate the psychotherapy. We want to treat the depression and anxiety. We want to avoid benzodiazepine because of the dependency and the limitation efficiency. Next, we want to talk about personality disorder and what caused the personality disorder. Personality disorder reflects enduring maladaptive pattern involuntary and involvement. Frontolimbic dysfunction affecting impulsive control and emotional regulation. That is what is causing it. A frontolimbic dysfunctional affecting impulsive control and emotional regulation. Early developmental attachment disturbance can cause a personality disorder. Stable cognitive schemes that disorder interpersonal interprediction, reinforcement of a maladaptive coping strategy, over time can cause the personality disorder. These patterns are ego-dystonic, meaning the patient often perceives them as appropriate or justified. That's why they are ego-dystonic. What are the symptoms? Symptoms perceives inflexible pattern of a thinking and behavior, impair interpersonal function, emotional dysregulation, or restrict affect, dependency, or cluster. Long-standing pattern beginning in a teenager years or early adulthood. For cluster patterns, we have cluster A, cluster B, and cluster C. So cluster A is add or recent behavior, eccentric behavior. Cluster B is dramatic, emotional, and impulsive behavior. Cluster C is anxious and fearful behavior. How are we going to rule out, or how are we going to diagnose? The diagnostic criteria include enduring pattern across the time and situation. So they are having this pattern or symptoms across the time and situation. The onset will be when they were teenager or early childhood. That's when the personality disorder began. Significant impairment in the social or occupational function. They are having a significant impairment in a social or occupational function. However, we want to exclude this is a mood disorder or a psychiatric disorder or substance disorder, because personality disorder is not mood disorder or psychiatric disorder or substance-induced disorders. They are personality disorder. We want to differentiate from other diagnoses. So differential diagnoses include bipolar disorder versus borderline personality disorder, episodic mood shift, and chronic instability. That's how we can differentiate. We want to differentiate schizophrenia spectrum disorder from schizotype personality disorder, persistent and episodic. We want to differentiate between one of them. Schizophrenia have persistent, while a schizotype personality disorder is episodic psychosis. We want to also differentiate between OCD versus obsessive compulsive personality disorder. One is a egocentric obsession, and one is ego-dystonic perfectionist. So OCD is a ego-dystonic obsession, while the obsession compulsive personality disorder is ego-centric syntonic perfectionist. So that's the difference. We want to also rule out between trauma-related disorders versus personality pathology. Symptomic clustering versus reflexive identify organization issue. How to select a treatment and what treatment do we need to select? Is psychotherapy is the first line for all personality disorder. Psychotherapy is the first line for all personality disorder. That dialectical behavior therapy is the most effective for borderline personality disorder. Cognitive behavior approaches are useful for cluster C disorder. Medications are added only if there is a symptoms. So medications that we can add if there is a symptoms include SSRIs for effective symptoms, mood stabilizer for impulsive, if they are impulsive, a typical antipsychotic medication for severe effective dysregulation. Next, we want to assess the risk of self-harm or interpersonal avoidance. We want to establish a structural psychotherapy as a primary treatment. We want to avoid a medication of a personality structural symptoms. Treat comorbidity of mood or anxiety disorder if they are present. Next, we want to talk about somatic symptoms and related disorders. Somatic symptoms disorders involve heightened interoceptor sensitivity, amplified body sensation and perception, cognitive misinterpretation of being physical sensation as a pathological. Disorganization of the attention network focus on excessively on a somatic symptoms. Those are the causes. Automatic arousal reinforcing symptoms perception. What are the clinical presentation for somatic symptoms and related disorders? It includes persistent physical symptoms that are distressing or functional impairment. They include excessive thoughts, feelings, behavior related to the symptoms, disproportional concern about medical illness. So they are concerned about medical illness, repeated healthcare usage, and reassurance seeking. They are always thinking they are sick. They are going to the hospital, clinic. They want to check themselves. They think they are ill, but it's not medically caused. Subtypes include somatic symptom disorder, illness anxiety disorder, conversion disorder, functional neurological symptom disorder. What are the diagnostic reasoning? Diagnosis requires positive symptoms of excessive health-related thoughts and behavior, not just the absence of a medical explanation. So they have a positive symptoms of excessive health-related thoughts and behaviors, not just the absence of a medical explanation. They have a persistent and functional impairment. We want to exclude medical disease through appropriate evaluation. We want to differentiate from facilitation disorder and malignancy when applicable. Differential diagnosis include we want to differentiate true medical illness versus somatic symptoms disorder. We want to differentiate anxiety disorder versus illness anxiety disorder. We want to differentiate depressive disorders versus somatic symptomatic presentation. We want to differentiate logical disease versus conversational disorder. After we did all that and we figured out that the somatic symptoms, what are the treatment? The treatment include cognitive behavior therapy, which is the first line of treatment, regular scheduling follow-up visits to reduce healthcare usage. We want to schedule them follow-up appointments, because if we don't schedule them, they will be scheduling themselves because they love to come to the hospital and the clinic. Second will be SSRIs to reduce the symptoms preoccupation. They are occupied, so we want to reduce that. We want to avoid unnecessary diagnostic testing because they are seeking check my head, check my leg, check my. I want to be tested on that disease. I want to be tested on that. I wanted to. Yeah, can I have X? I have seen people who come to the hospital and say, I want to have X-ray, I want to have MRI, I want to have a surgery, something wrong with my stomach, something wrong with my heart, something. It could be, but we want to rule out medical first, and then we want to address that somatic symptoms if it's not medical or psychiatric or substance. What is the next step? Promote consistency. Validate but not reinforce the reassurance. You want to promote consistent. You want to validate that they feel in this way. I know you are feeling this way. I hear you are feeling this way, but it's not mean that we are going to do everything they requested, because we already know and diagnosed with them as somatic symptoms. We want to establish structural follow-up care with one provider, when possible, because that provider knows the patient, know what they are requesting, know they will have a connection with that person. It will be consistent care, so we want to establish that. We want to screen for comorbid anxiety or depression disorder. Are they having anxiety disorder or depression disorder? That's why they want to do this. So we want to treat those if they are having. Next, we want to continue feeding and eating disorder. Feeding and eating disorder involve dysregulation of a reward pathways affecting food reinforcement, serotonergic and dopamine imbalance affecting appetite and impulsive control, cognitive distortion. Cognitive distortion relate to body image and self-worth. Those are the causes. Hypothalamic regulation disturbance affecting the hunger and safety. So the feeding and eating disorder is caused by regulation of a reward pathway affecting the food reinforcement, serotonin and dopamine imbalance affecting the appetite and impulsive control, cognitive distortion relate to body image and self-worth, hypothalamic regulation that disturbance affecting the hunger and safety. So what are the symptoms? They include anorexia nervosa, bulimia, binging disorder. So anorexia nervosa is a restriction of energy intake, significantly low body weight, intensive fear of gaining weight, distorted body image. Those are the symptoms. Bulimia nervosa, they have recurrent binging eating followed by compensatory behavior such as purging. They want to eat and vomit, eat and vomit, eat and vomit. Binge eating disorder is a recurrent Vinci episode without compensatory behavior. How are we going to diagnose them? Diagnosis requirement include a specific behavior pattern such as restriction, binging, or birching. Psychological distress regarding a body image or control. So, differential diagnosis of eating disorders include nutrition rehabilitation is the priority in anxiety, anorexia nervosa. So nutrition rehabilitation is the priority in anorexia nervosa. Cognitive behavior therapy is the first line of treatment for bulimia and binging eating disorder. So binging eating disorder and bulimia. First line is a cognitive behavior therapy. Bulimia and binging eating disorder. SSRIs are the effective for the anxiety. Family-based therapy is important if they are teenagers. Next clinical step is we want to assess a medical stability, include electrolyte abnormality and cardiac risk. We want to determine the need for inpatient medical stabilization in anorexia nervosa. If they are having anorexia nervosa, we want to determine if they are need for inpatient medical stabilization. We want to initiate structural nutritional rehabilitation. We want to address the disorder conditions through psychotherapy. Thank you for joining me today. I will love to see you in my next video. Subscribe. Thank you.